Question 1. A 45-year-old male is found unresponsive with shallow, gurgling respirations at a rate of 6 breaths per minute. His pulse is weak and thready at 110 bpm. He has pinpoint pupils and a medical alert bracelet indicating a history of opioid use disorder. After ensuring scene safety and personal protective equipment, what is the most immediate and critical intervention? A. Administer intranasal naloxone. B. Perform a rapid trauma assessment. C. Insert an oropharyngeal airway and begin ventilations with a bag valve mask. D. Prepare for immediate transport to the nearest hospital. Answer: C. Insert an oropharyngeal airway and begin ventilations with a bag valve mask. The concept tested here is the priority of airway and breathing management in an unresponsive patient with respiratory compromise. The keywords unresponsive, shallow, gurgling respirations, and 6 breaths per minute clearly indicate inadequate breathing requiring immediate intervention. While naloxone is indicated for opioid overdose, establishing and maintaining an airway and providing ventilatory support, like with an oropharyngeal airway and bag valve mask, is always the first and most critical step, as the patient is not breathing adequately to sustain life, regardless of the cause. Ensuring effective ventilation will oxygenate the brain and body while further interventions, such as naloxone administration, can be prepared or given. Always remember that airway and breathing, the A and B of ABCs, take precedence over circulation or medication administration in an actively decompensating patient. Question 2. During a cardiac arrest resuscitation, the AED advises no shock advised. The patient is unresponsive, apneic, and pulseless. What is the immediate next step? A. Check for a pulse and rhythm. B. Discontinue CPR and prepare for transport. C. Continue chest compressions. D. Administer 2 mg of intravenous epinephrine. Answer: C. Continue chest compressions. This question tests your understanding of the immediate actions following an AED analysis in a cardiac arrest scenario, specifically when a shock is not advised. The keywords no shock advised, unresponsive, apneic, and pulseless confirm the patient remains in cardiac arrest. When the AED advises no shock advised, it means the rhythm is either asystole or pulseless electrical activity, PEA, neither of which are shockable rhythms. In such cases, the immediate priority is to continue high-quality chest compressions without interruption to maintain vital organ perfusion. Do not pause CPR unnecessarily, every second counts in cardiac arrest. Question 3. A 68-year-old male complains of sudden onset, severe, tearing pain in his chest that radiates to his back. He is pale and diaphoretic. His blood pressure is 180/100 mmHg in the right arm and 140/80 mmHg in the left arm. What condition should the EMT most suspect? A. Acute myocardial infarction. B. Unstable angina. C. Aortic dissection. D. Spontaneous pneumothorax. Answer: C. Aortic dissection. This question evaluates your ability to differentiate between various cardiovascular emergencies based on specific symptom clusters. The critical keywords are sudden onset, severe, tearing pain, radiates to his back, and especially the significant blood pressure difference between arms. While chest pain is common in myocardial infarction, the tearing quality and back radiation, combined with a differential blood pressure, a difference of greater than 20 mm of mercury systolic, are classic hallmark signs of an aortic dissection, where the inner layers of the aorta tear. Recognizing this specific constellation of symptoms is vital because the management and prognosis differ significantly from other causes of chest pain. Always consider an aortic dissection when presented with sudden, severe, tearing pain and unequal pulses or blood pressures. Question 4. A 2-year-old child presents with a high fever, drooling, and inspiratory stridor. The child is sitting upright and appears anxious, refusing to lie down. What is the most appropriate initial management for this patient? A. Administer humidified oxygen via nasal cannula. B. Visually inspect the airway with a tongue depressor. C. Attempt to comfort the child and transport immediately in a position of comfort. D. Prepare for immediate intubation by a paramedic. Answer: C. Attempt to comfort the child and transport immediately in a position of comfort. This question tests your knowledge of managing a pediatric patient suspected of epiglottitis, a severe airway emergency. The key clues are the child's age, young, high fever, drooling, inspiratory stridor, anxious, and sitting upright, refusing to lie down, which are all classic signs of epiglottitis. In such a case, minimizing any procedures or interventions that could agitate the child and potentially trigger complete airway obstruction is paramount. Providing a calm environment and transporting the child in a position of comfort while preparing for advanced airway management if needed is the safest approach. Avoid any direct oral examination as it can cause laryngospasm and immediate airway closure. Question 5. You are transporting a patient with a known history of severe allergic reactions to bee stings. The patient was stung and is now complaining of generalized itching, hives, and difficulty breathing with wheezing. The patient is anxious, and their blood pressure is 90/60 mmHg. What is the most appropriate intervention? A. Administer oxygen via non-rebreather mask and monitor vital signs. B. Assist the patient with their prescribed bronchodilator inhaler. C. Administer intramuscular epinephrine. D. Transport rapidly in a supine position. Answer: C. Administer intramuscular epinephrine. This question evaluates your understanding of anaphylaxis management. The keywords severe allergic reactions, generalized itching, hives, difficulty breathing with wheezing, and especially blood pressure is 90/60 mm of mercury, indicating hypotension, are classic signs of anaphylactic shock. Epinephrine is the definitive, life-saving treatment for anaphylaxis because it addresses both the bronchoconstriction and vasodilation that lead to shock. While oxygen and bronchodilators may be supportive, they do not resolve the underlying systemic allergic reaction causing the life-threatening symptoms. Always remember that epinephrine is the first-line drug for anaphylaxis, especially when there are signs of airway compromise or circulatory shock. Question 6. A patient is found unresponsive with hot, flushed, dry skin, a rapid, weak pulse, and a core body temperature of 105 degrees Fahrenheit 40.6 degrees Celsius. The patient's friends state they were hiking all day in direct sunlight. What is the most appropriate initial intervention? A. Administer oral fluids. B. Move the patient to a cooler environment and begin rapid active cooling. C. Apply warm compresses and blankets. D. Administer a rapid intravenous fluid bolus of D5W. Answer: B. Move the patient to a cooler environment and begin rapid active cooling. This question tests your ability to identify and manage heat stroke. The crucial keywords are unresponsive, hot, flushed, dry skin, rapid, weak pulse, and a core body temperature of 105 degrees Fahrenheit. These symptoms are characteristic of heat stroke, a life-threatening emergency where the body's thermoregulation system fails. The most immediate and critical intervention is to move the patient out of the hot environment and rapidly lower their core body temperature through active cooling methods such as applying cool, wet compresses, fanning, or even immersing in cool water if practical and safe. Oral fluids are contraindicated in an unresponsive patient, and warming measures would be harmful. Rapid cooling is the priority to prevent further organ damage. Question 7. You arrive on scene to find a 28-year-old male who was ejected from his vehicle during a high-speed collision. He is unresponsive, has significant facial trauma, and is bleeding profusely from his nose and mouth. Respirations are shallow and gurgling. What is the most critical immediate action regarding airway management? A. Perform a head tilt, chin lift maneuver. B. Insert an oropharyngeal airway. C. Suction the airway and perform a jaw thrust maneuver. D. Attempt nasotracheal intubation. Answer: C. Suction the airway and perform a jaw thrust maneuver. This question assesses your priority setting in a traumatic airway emergency with facial trauma. The keywords ejected from vehicle, high-speed collision, unresponsive, significant facial trauma, and bleeding profusely from nose and mouth strongly indicate potential spinal injury and a compromised airway due to fluids. In this scenario, managing blood and secretions is paramount, so suctioning is the first step to clear the airway. Given the high-energy trauma, a jaw thrust maneuver is preferred over a head tilt, chin lift to minimize potential cervical spine movement. Establishing a patent airway is critical for survival in trauma patients and often requires immediate removal of obstructions first. Question 8. A 55-year-old male with a history of diabetes reports sudden onset of blurred vision, numbness, and tingling in his right arm, and difficulty speaking. His blood glucose is 120 milligrams per deciliter. He last appeared normal approximately 2 hours ago. What is the most appropriate field management? A. Administer oral glucose. B. Administer aspirin and assist with nitroglycerin. C. Rapid transport to a stroke center with pre-hospital notification. D. Administer oxygen via nasal cannula and monitor closely. Answer: C. Rapid transport to a stroke center with pre-hospital notification. This question tests your ability to recognize and manage an acute stroke. The keywords sudden onset, blurred vision, numbness and tingling in his right arm, and difficulty speaking are classic signs of a cerebrovascular accident, stroke. The last normal time, 2 hours ago, is crucial for determining potential eligibility for thrombolytic therapy at a stroke center. Given the time-sensitive nature of stroke treatment, immediate transport to a facility capable of stroke care, with pre-hospital notification, is the most appropriate action. While supportive care like oxygen is important, delaying transport for other interventions or further on-scene assessment is detrimental to patient outcome. Question 9. You are managing a 30-year-old male who sustained a severe burn to his left arm from an electrical outlet. He is alert and complaining of severe pain. His vital signs are stable, but the burned area appears charred and insensate. What is the immediate priority for this patient? A. Apply moist sterile dressings to the burn. B. Provide pain management. C. Assess for an entrance and exit wound and cardiac rhythm abnormalities. D. Transport immediately to a burn center. Answer: C. Assess for an entrance and exit wound and cardiac rhythm abnormalities. This question focuses on the specific dangers associated with electrical burns. While pain management and burn care are important, the keyword electrical outlet highlights that this is an electrical injury, which has unique and potentially lethal systemic effects beyond the visible skin burn. The most immediate priority for an electrical burn patient is to assess for an entrance and exit wound, indicating the path of current through the body, and to monitor for cardiac rhythm abnormalities, as electrical current passing through the heart can cause immediate or delayed dysrhythmias, even if the patient initially appears stable. The visible burn is often less severe than the internal damage. Question 10. A 72-year-old female fell, striking her head. She is confused, disoriented, and has a scalp laceration that is bleeding minimally. Her Glasgow Coma Scale, GCS, score is 13. Which of the following findings would be most concerning for increasing intracranial pressure, ICP? A. Hypotension. B. Bradycardia. C. Tachypnea. D. Dilated and reactive pupils. Answer B. Bradycardia. This question assesses your knowledge of signs of increasing intracranial pressure, ICP, after head trauma. The keywords confused, disoriented, and GCS score is 13 indicate a significant head injury. The most concerning sign among the choices for increasing ICP, specifically as part of Cushing's triad, is bradycardia, slow heart rate. Cushing's triad is a classic indicator of severe increased ICP and consists of hypertension, widening pulse pressure, bradycardia, and irregular respirations, e.g., Cheyne-Stokes or Biots. Hypotension is more indicative of hypovolemic shock, while tachypnea might be a compensation for acidosis or other issues, and dilated and reactive pupils are less concerning than fixed or unequal pupils. Question 11. A 4-year-old child ingested an unknown quantity of their grandparents' cardiac medication. The child is drowsy but responds to verbal stimuli. What is the most important piece of information to obtain from the family for the emergency department? A. The child's last meal. B. The exact name and dosage of the ingested medication. C. The child's immunization record. D. The family's insurance information. Answer B. The exact name and dosage of the ingested medication. This question emphasizes the critical information needed in a pediatric poisoning emergency. The keywords ingested unknown quantity and cardiac medication indicate a potentially life-threatening overdose. For poisonings, the most important information for guiding treatment is knowing precisely what was ingested, the exact name of the medication, and how much, the dosage, as this directly dictates the potential toxicity and necessary antidote or supportive care. While other information may be helpful, the specific substance and quantity are paramount for the emergency department to initiate appropriate management quickly. Always prioritize obtaining specific medication information in overdose situations. Question 12. A 35-year-old pregnant patient, G3P2, 36 weeks gestation, is experiencing regular, painful contractions every 3 minutes, lasting 60 seconds. She feels an urge to push. Upon assessment, you note crowning. What is the most appropriate action? A. Place the patient in a supine position and prepare for rapid transport. B. Instruct the patient to try to hold back the pushing urges. C. Prepare for an imminent field delivery. D. Administer oxygen and initiate and 4-line. Answer C. Prepare for an imminent field delivery. This question assesses your recognition of imminent childbirth. The keywords 36 weeks gestation, regular, painful contractions every 3 minutes, lasting 60 seconds, urge to push, and especially crowning are all definitive signs that delivery is actively underway and cannot be delayed. At this point, attempting transport or delaying delivery is inappropriate and potentially dangerous for both mother and baby. The most appropriate action is to prepare for and assist with a safe field delivery, focusing on controlling the delivery and ensuring immediate care for the newborn. Question 13. You are assessing a patient complaining of a sudden onset of the worst headache of my life. The patient is alert but disoriented, and their blood pressure is significantly elevated. There is no history of trauma. What condition should you most suspect? A. Migraine headache. B. Ischemic stroke. C. Subarachnoid hemorrhage. D. Tension headache. Answer C. Subarachnoid hemorrhage. This question tests your ability to identify a specific type of severe headache that indicates a critical medical emergency. The key phrase "worst headache of my life" is a classic, textbook presentation for a subarachnoid hemorrhage, SAH, which is bleeding into the space surrounding the brain, often caused by a ruptured aneurysm. While other conditions can cause headaches, This specific description, especially without trauma, is highly indicative of SAH. Recognizing this specific complaint is crucial for rapid transport to a definitive care facility, as SAH can quickly lead to severe neurological deficits or death. Question 14. A patient with a known history of chronic obstructive pulmonary disease, COPD, is experiencing severe shortness of breath. They are anxious, speaking in 2 to 3 word sentences, and have accessory muscle use. SpO2 is 88% on room air. What is the most appropriate initial oxygen delivery device? A. Nasal cannula at 2 to 4 liters per minute. B. Non-rebreather mask at 15 liters per minute. C. Venturi mask at 28%. D. Bag valve mask assisted ventilations. Answer: B. Non-rebreather mask at 15 liters per minute. This question assesses your understanding of oxygen therapy in patients with chronic respiratory conditions, specifically COPD, when they are in acute respiratory distress. The keywords severe shortness of breath, anxious, speaking in 2 to 3 word sentences, accessory muscle use, and SpO2 of 88% on room air indicate significant respiratory distress and hypoxia, despite the patient's COPD history. While it was once thought that high-flow oxygen could suppress the respiratory drive in COPD patients, current guidelines prioritize correcting hypoxia in acute situations. A non-rebreather mask at 15 liters per minute provides the highest concentration of oxygen and is appropriate for severe hypoxia. Once the immediate crisis is managed and the patient's condition stabilizes, a more precise device like a Venturi mask might be considered, but initial severe hypoxia demands maximum oxygen delivery. Question 15. You are managing a 6-month-old infant presenting with a sudden onset of inconsolable crying, drawing legs up to the chest, and current jelly stools. The infant is pale and lethargic between crying episodes. What condition should you most suspect? A. Gastroenteritis. B. Appendicitis. C. Intussusception. D. Pyloric stenosis. Answer: C. Intussusception. This question tests your knowledge of specific pediatric abdominal emergencies. The critical keywords are 6-month-old infant, sudden onset of inconsolable crying, drawing legs up to the chest, classic sign of abdominal pain, and particularly current jelly stools. These are the classic signs and symptoms of intussusception, a condition where one part of the intestine slides into another, causing an obstruction. While other conditions cause abdominal pain, the combination of these specific symptoms, especially the characteristic stool, should immediately raise suspicion for intussusception. Rapid transport is essential for this time-sensitive surgical emergency. Question 16. A 22-year-old male was found down after a suspected overdose. He is unresponsive, apneic, and has a faint carotid pulse of 50 bpm. You have administered 2 mg of intranasal naloxone, but there is no improvement after 4 minutes. What is the next most appropriate action? A. Administer a second dose of naloxone. B. Initiate high-quality chest compressions. C. Insert an advanced airway device. D. Begin positive pressure ventilations with a bag valve mask. Answer: D. Begin positive pressure ventilations with a bag valve mask. This question tests the priority of interventions in an unresponsive, apneic patient after initial naloxone administration. The crucial keywords are unresponsive, apneic, and no improvement after 4 minutes. While naloxone is important, the patient is still not breathing, meaning they are critically hypoxic. The most immediate and life-saving intervention is to ensure adequate oxygenation and ventilation by initiating positive pressure ventilations with a bag valve mask. While a second dose of naloxone might be considered, ensuring breathing comes first, as even a successful naloxone dose won't immediately reverse all respiratory depression. Don't wait for the naloxone to work fully if the patient isn't breathing. Question 17. During a large multi-vehicle collision, you are the first EMS unit on scene. There are multiple injured patients. As you approach, you observe a vehicle on fire and downed power lines. What is your immediate priority? A. Begin triaging patients immediately. B. Call for additional resources and establish scene safety. C. Access the most critically injured patient. D. Secure the uninjured bystanders. Answer: B. Call for additional resources and establish scene safety. This question emphasizes the paramount importance of scene safety and resource management in a mass casualty incident, MCI. The keywords large multi-vehicle collision, multiple injured patients, vehicle on fire, and downed power lines clearly indicate a hazardous and complex scene. Before any patient contact or triage can begin, the immediate priority is always to ensure the safety of yourself, your crew, and other responders by identifying and mitigating hazards and calling for appropriate additional resources, fire, power company, more EMS units. You cannot effectively help patients if the scene itself is dangerous. Always prioritize scene safety above all else. Question 18. You are assessing an alert and oriented 80-year-old patient who is complaining of chest pain. They refuse all treatment and transport, stating they understand the risks and want to stay home. Their family is present and insists they go to the hospital. What is the most appropriate action for the EMT? A. Transport the patient against their will due to family request. B. Document the patient's refusal thoroughly and advise the family on follow-up care. C. Contact medical direction for guidance on obtaining consent from the family. D. Inform the patient that refusal is not an option given the severity of the symptoms. Answer: B. Document the patient's refusal thoroughly and advise the family on follow-up care. This question tests your understanding of patient autonomy and the legal principle of refusal of care. The keywords alert and oriented, understands the risks, and refuse all treatment and transport are critical. A mentally competent adult has the right to refuse medical care, even if it seems against their best interest or if family members disagree. The EMT's role is to ensure the patient is fully informed of the risks of refusal, document this extensively, and advise on alternative care or when to call for help again. You cannot force an alert and oriented adult to accept treatment or transport. Question 19. A 40-year-old male with a history of alcohol abuse is found unresponsive with shallow, slow breathing. His skin is cool and clammy. His pupils are normal and reactive. His blood glucose level is 45 mg per deciliter. What is the most immediate intervention? A. Administer intravenous thiamine. B. Administer dextrose 50% 4. C. Begin rapid transport to the hospital. D. Insert an advanced airway. Answer: B. Administer dextrose 50% 4. This question requires you to prioritize interventions for an unresponsive patient with hypoglycemia. The keywords unresponsive, history of alcohol abuse, shallow, slow breathing, and crucially, blood glucose level is 45 mg per deciliter point directly to severe hypoglycemia as the immediate life threat. Hypoglycemia, low blood sugar, can cause unresponsiveness and respiratory depression and is rapidly reversible with glucose administration. Administering dextrose 50% 4 will raise the patient's blood sugar quickly, often leading to rapid improvement in mental status and respiratory effort. While transport is important, correcting the underlying hypoglycemia is the most immediate and effective intervention for this specific condition. Question 20. You are performing CPR on an adult patient. The AED arrives and is attached. It analyzes the rhythm and advises shock advised. After clearing the patient, you deliver the shock. What is the immediate next action? A. Reassess the patient's pulse. B. Continue chest compressions immediately. C. Remove the AED pads and prepare for transport. D. Administer rescue breaths. Answer: B. Continue chest compressions immediately. This question tests your knowledge of the immediate post-shock protocol in adult cardiac arrest. The keywords shock advised, deliver the shock, and immediate next action are crucial. According to current resuscitation guidelines, e.g., 2020 AHA, still relevant for 2025 updates, after delivering a shock, you must immediately resume high-quality chest compressions without delay. Do not pause to check for a pulse or rhythm. Compressions are paramount to maintaining perfusion. Checking for a pulse only occurs after 2 minutes of high-quality CPR or if the patient shows signs of life. Question 21. A 6-year-old child presents with a sudden onset of barking cough, stridor, and mild respiratory distress, but no fever. Their parents report the symptoms worsened at night. What condition is most likely? A. Epiglottitis. B. Croup. C. Bronchiolitis. D. Asthma exacerbation. Answer: B. Croup. This question assesses your ability to differentiate common pediatric respiratory conditions. The key phrases are 6-year-old child, sudden onset of barking cough, stridor, mild respiratory distress, and no fever, with symptoms worsening at night. This constellation of symptoms, particularly the barking cough and the absence of a high fever, is classic for croup, laryngotracheobronchitis, a viral infection causing swelling around the vocal cords. Epiglottitis typically presents with high fever, drooling, and severe distress, while bronchiolitis is more common in infants with wheezing, and asthma has a history of triggers and wheezing. Question 22. A patient presents with a deep laceration to their forearm that is actively spurting bright red blood. They are pale and appear anxious. What is the most effective immediate intervention to control this hemorrhage? A. Apply a pressure dressing. B. Elevate the extremity. C. Apply a tourniquet proximal to the wound. D. Apply direct pressure with a sterile dressing. Answer: D. Apply direct pressure with a sterile dressing. This question tests the primary method for controlling significant external bleeding. The keywords deep laceration, actively spurting bright red blood, and pale and anxious indicate severe arterial bleeding. The most effective initial intervention for almost all external hemorrhage is direct pressure applied with a sterile dressing directly to the wound. While a pressure dressing might follow, and elevation can be helpful, direct pressure is the immediate action. A tourniquet is a last resort for uncontrolled life-threatening hemorrhage that doesn't respond to direct pressure, or for an amputation. Always start with direct pressure for active bleeding. Question 23. You arrive on scene to a single-car motor vehicle collision. The driver is unrestrained and found lying across the front seats. They are conscious but complain of severe neck pain and numbness in both legs. What is the most appropriate method for extrication? A. Allow the patient to self-extricate with verbal guidance. B. Perform an emergency move to a long backboard. C. Apply a cervical collar and use a KED, Kendrick extrication device, or similar short spinal immobilization device. D. Use a blanket drag to remove the patient quickly. Answer: C. Apply a cervical collar and use a KED, Kendrick extrication device, or similar short spinal immobilization device. This question assesses your approach to extrication and spinal immobilization in a conscious, entrapped trauma patient. The keywords unrestrained, lying across the front seats, severe neck pain, and numbness in both legs strongly suggest a potential spinal injury. In this scenario, where the patient is conscious and not in immediate danger, like fire or uncontrolled bleeding, a controlled extrication with spinal immobilization is paramount. Applying a cervical collar and using a KED or similar device allows for spinal immobilization before carefully removing the patient from the vehicle, minimizing further injury. Emergency moves are reserved for immediate life threats. Question 24. A patient is hyperventilating rapidly with carpal pedal spasms and numbness around their mouth. They report feeling lightheaded. What is the most appropriate initial intervention? A. Administer albuterol via nebulizer. B. Have the patient breathe into a paper bag. C. Coach the patient to slow their breathing. D. Administer supplemental oxygen. Answer: C. Coach the patient to slow their breathing. This question evaluates your understanding of managing hyperventilation syndrome. The key phrases are hyperventilating rapidly, carpal pedal spasms, cramping of hands/feet, and numbness around their mouth. These are classic symptoms of hyperventilation, which leads to hypocapnia, low CO2 levels, and respiratory alkalosis. The most appropriate initial intervention is to coach the patient to slow their breathing rate. This allows CO2 levels to rise back to normal. While it was once common practice, having a patient breathe into a paper bag is generally no longer recommended due to the risk of exacerbating hypoxia if the underlying cause isn't just hyperventilation. Oxygen is typically not needed unless there's underlying hypoxia. Question 25. You are called to a construction site for a worker who fell 30 feet onto a pile of rebar. The patient is unconscious, breathing at 8 breaths per minute, and has significant impaled objects to the chest and abdomen. What is the most immediate life-saving intervention after securing the airway? A. Stabilize the impaled objects. B. Rapidly transport to a trauma center. C. Administer 4 fluids. D. Decompress a potential tension pneumothorax. Answer: D. Decompress a potential tension pneumothorax. This question tests your ability to prioritize life threats in severe multisystem trauma. The keywords fell 30 feet, unconscious, 8 breaths per minute, and significant impaled objects to the chest and abdomen indicate severe trauma with potential for immediate life threats. While stabilizing impaled objects, transport, and 4 fluids are important, a patient breathing at 8 breaths per minute after blunt or penetrating chest trauma, especially with high-impact falls, strongly suggests a tension pneumothorax. This condition causes immediate cardiorespiratory collapse and requires rapid decompression, e.g., needle decompression, as a time-critical, life-saving intervention prior to transport, as it directly impacts breathing and circulation. Failure to address this immediately will result in death.